Hello, doctor. Greetings from Orchidia Pharmaceutical Company. I hope you, your family, and all your beloved ones are safe and in good health. Today, I'm going to talk about glaucoma patients. Trabecular brings patients to the targeted IOP regardless of their baseline. Trabecular reduces the IOP by 30% for patients whom IOP is more than 25 mm mercury. And for those whom IOP is more than 30 mm mercury, Trabecular could reduce it up to 50% of the IOP. Another product for your glaucoma patients is Alpha Nova. Alpha Nova is the perfect add-on therapy with a superior neuroprotective effect, along with less incidence of ocular allergy as Alpha Nova is preserved with sodium purite. Finally, I would like to remind you with OcuGuard, a tailored formula of vitamins, minerals, and herbs. Thank you for your time.
Good evening, everybody. It's our pleasure to continue with you our program for conveying all the details about basic glaucoma. It's our pleasure today to have with us our professor, Dr. Ahmed Hussam Abdallah, Professor of Ophthalmology in Alexandria Department, University of Alexandria. He's going to talk with us about his experience in gonioscopy. Gonioscopy is one of the most important basic examinations needed for an ophthalmologist to experience and to master in order to diagnose and to start his journey in glaucoma therapy. Please, Dr. Hussam.
First of all, I'd like to thank Professor Abdelhamid for organizing such good meetings. I would like to thank Orchidia Company for always helping us and supporting us. And I would like to thank Professor Dr. Nader for supplying me with some of the clinical pictures in my presentation. My presentation today is about gonioscopy. It is one of the neglected techniques by most of the ophthalmologists, but as Dr. Abdelhamid said, it is a very important step in diagnosing and treating glaucoma. Why should I do gonioscopy? Gonioscopy should be done to recognize angle landmarks such as level of iris insertion, shape and profile of peripheral iris. ايوه
حضرتك ممكن تشير السكرين.
نعم؟
شير السكرين.
مش سامع.
شير السكرين.
انا عملت شير سكرين.
حضرتك لسه ما فتحتش السكرين.
لا. طيب ثانية. أنا كده فاتح البرزنتيشن.
حضرتك ارجع للزوم واعمل شير للسكرين يا دكتور.
أرجع للزوم. شير سكرين. كده شيرت.
تمام يا دكتور. حضرتك بس دوس بلاي على الكينوت.
As I said, we do gonioscopy to recognize angle landmarks such as level of iris insertion, shape and profile of peripheral iris, estimated width of the angle approach, degree of trabecular pigmentation, and most important, area of iridotrabecular apposition or synecdoche. There are other methods to examine the angle, like the UBM, anterior segment OCT, Schwalbe photography. But we must learn about the basic technique of doing gonioscopy. If we examine a patient by the slit lamp, we can't see the angle. Why we can see it? Because rays emitting from the angle makes total internal reflection. To cancel or overcome this total internal reflection, we use a lens, either a prism or a mirror as in direct gonioscopy. There are two main methods of gonioscopy, direct gonioscopy and indirect gonioscopy. In direct gonioscopy, there are two types, without indentation, like the Goldman 3 mirror, and with indentation, like the 4-mirror lens. We're going to speak about it later. Direct gonioscopy, the most common used lens is the Kepi lens. It could be used by handheld slit lamp or in the operating theater by the operating microscope. It has several advantages. Straight on in view, it is not inverted like the mirror. Angle of visualization is variable, more panoramic, and we can compare both eyes by putting two lenses at the same time into both eyes of the patient. However, it is inconvenient and difficult to master, and special equipment needed, such as handheld slit lamp. The most common method of gonioscopy we all know is the indirect gonioscopy. This can be done by either Goldman 3 mirror, or in the past there was Goldman 1 mirror, and we use the dome-shaped mirror to examine the angle. Here, how to put the lens. The lens is held with one hand, usually the right hand, and the lower lid is inverted with the left hand. The patient is instructed to look upwards, approach the eye from slightly below the center, and insert the lens rim first into the inferior fornix. Then gently place the lens on the eye to get the air out with the patient looking upwards, and then let the patient look straight forward. Other type of indirect gonioscopy is the 4-mirror lens. There are several types, either the Posner 4-mirror lens, there is the Zeiss 4-mirror lens, and there is the Sussman 4-mirror lens. In order to put it, we oppose the cornea by gentle upward speed of the upper lid and lashes. Touch the cornea with correct amount of pressure, and it must be central, because if we do excess pressure, there will be wrinkles in the cornea, which will hide the view. And if it is not central, we cannot see the angle quite. General guidelines to how to examine the angle by gonioscopy. First, we do an external examination first. As you can see here, we can see either here pseudo-exfoliation, here we can see glaucomoflecken, means previous acute attack. Then tonometry is usually done before gonioscopy, because gonioscopy by pressure of the eye may alter the tonometry. Use topical anesthesia. Make sure that the patient is comfortable and his eyes are well aligned on the slit lamp. Use a magnification between 10 and 25. Don't use larger magnification. Use a fairly short and narrow beam, about 2 or 3 millimeters. And it is important to darken the room, because if there is light in the room, this will lead to pupillary constriction and will make a narrow angle appear falsely opened. Advantages of indirect gonioscopy than direct: it is preferred by most ophthalmologists, quick, convenient, no special equipment, you just need the lens. By using the slit lamp, we can use different or variable magnification and illumination. It can create a corneal wedge, and I'm going to explain this. And the most important, indirect gonioscopy allows differentiation of apposition and synechial angle closure. Disadvantages: mirror images can be confusing because the picture is inverted. Also, you must take care from excessive pressure on the cornea. By the use of the Goldman 3-mirror lens, excessive pressure will lead narrowing of the angle. And the reverse, if we're using 4-mirror lens, excessive pressure will open the angle and false wide angle. Here is one of the most important slides to understand, to identify structures of the angle of the anterior chamber. It's called the corneal wedge. As we can see here, this line is the pipeline of the endothelium. This here is the pipeline of the epithelium. Both of them meet at a point where there is Schwalbe's line. So in order to identify Schwalbe's line and identify all the structure of the angle, we must look for the corneal wedge and identify where Schwalbe's line begins. As an example, here in the picture in the right, the angle is pale here. all this area, we can think that it is the cornea, and we can think this is trabecular meshwork. But if we look at the corneal wedge, here is the Schwalbe line, and here the trabecular meshwork is non-pigmented. And this is not the trabecular meshwork, this is the ciliary body band. On this picture, here is the corneal wedge. So here is the Schwalbe line. This pigmentation is pigmentation anterior to Schwalbe line, either post-inflammatory or as in pseudo-exfoliation, some what we call some Paulesti line. We don't mistake this for trabecular meshwork, especially if we're doing angle treatment as argon laser trabeculoplasty or selective laser trabeculoplasty. So the first point I'm stressing is before starting examination, the angle, examine the corneal wedge and detect where is Schwalbe line exactly. Here it is, and in this picture here is the Schwalbe line. So sometimes we may be confused when the iris covers the trabecular meshwork. Here it is very easy to mistake non-pigmented trabecular meshwork for the scleral spur, and we can mistake a pigmented Schwalbe line for trabecular meshwork. Here, indentation gonioscopy is very important to identify angle structures. Normal angle structures, as we all see, we start, as I said before, with the Schwalbe line. This is followed by the non-pigmented trabecular meshwork. This is followed by the pigmented trabecular meshwork, which is a functional trabecular meshwork. This is followed by the scleral spur, and lastly, the ciliary body band and the iris. Not each angle shows all these structures, as we are going to speak about classification of the angle. As I said, first thing is the Schwalbe line. It is the termination of the descendens membrane. If there's pigmentation in it or above it, it's called some Paulesti line. And it is the most important landmark to identify trabecular meshwork in narrow angles. Here is the Schwalbe line, and here is the trabecular meshwork posterior to it. Again, pigmented or Schwalbe line, non-pigmented anterior trabecular meshwork, pigmented trabecular meshwork, scleral spur, ciliary body band, and the iris. Sometimes we see blood vessels in the angle of the anterior chamber. It's important to differentiate normal blood vessels of the anterior chamber from neovascularization, which may be present on diabetic retinopathy or central retinal vein occlusion. Normal vessels are radially oriented, thick, non-branching, and they never cross the scleral spur. Neovascularization are finer, they are borizing, not radial, and they cross the scleral spur. Also, it is important in the angle to differentiate between iris processes, which are normal variation or physiological variation of the angle, from synechia, which is due to previous iritis or previous acute attack of glaucoma. Iris processes are fine, synechia are broad. Iris processes extend into the scleral spur. Synechia extend beyond scleral spur. Important, iris processes follow the concavity of the recess of the angle, but synechia bridge the concavity. The iris processes underlying structures are seen, and iris moves with indentation. Synechia obscure structures and resist movement. As we can see here in the picture below, this is the iris processes. As you can see, they're fine, just extend to the scleral spur, and they follow concavity of the recess. On the other hand, synechia are broad, they cross the scleral spur, and they bridge. They don't follow the concavity of the angle. What is indentation gonioscopy? Indentation gonioscopy, it is very important, and it should be done in all glaucoma cases, especially when the iris is convex. By indentation gonioscopy, use the 4 mirror lens, either the Zeiss, the Posner, and we press on the central part of the cornea. This will lead to aqueous to go in the angle, and one or two things will happen. If it is just a position between the iris and the cornea, we're going to see the trabecular meshwork, but if there is synechia, we are going to see synechia, or we're going to see nothing if there's total synechial closure. So it should be performed in all glaucoma cases to differentiate a positional versus synechial closure in pupillary block. It measures the extent of angle closure. We can also diagnose with it plateau iris configuration, or pseudo-plateau configuration, and it identifies lens-induced angle closure. As we can see here, after pressure, the aqueous goes in the angle, and we find here the angle is opened. Also here, what will happen when we press by the lens, aqueous passes to the periphery, and it will open a part of the angle. Here we can see this part is closed and this part is open. Here it is totally closed. Also here, after indentation, we can see synechia present. Also, it can help us to identify plateau iris configuration, but what we call the double hump sign. If we do gonioscopy or UBM and find the double hump sign, we can diagnose plateau iris. Also, when we have sometimes an iris cyst, there is pseudo plateau iris, and it could be diagnosed by gonioscopy. Also, pseudomorphic angle closure or lens-induced can be identified by gonioscopy. So here we'll try to simplify what we said when you examine the patient by gonioscopy. First, as I said, we identify Schwalbe's line and look for all the structures. Then you see if the scleral spur is visible, then this angle is open. It is an open angle glaucoma. If the scleral spur is invisible, we do indentation gonioscopy. If by indentation gonioscopy there is synechia, it is a primary angle closure glaucoma. If there is no synechia, we measure the intraocular pressure. If the intraocular pressure is normal, it is primary angle closure suspect. If the intraocular pressure is raised, it is primary angle closure. So by gonioscopy, we can differentiate between open angle and closed angle. And by indentation gonioscopy, we can differentiate between primary angle closure suspect, primary angle closure, and chronic angle closure by synechia. How to grade the angle? There are different grading methods, either the Spess, Scheffer, or modified Scheffer. Spess is more complicated, and it talks about 4 things. It talks about insertion of the iris root, if it is anterior to the Schwalbe's line A, B behind Schwalbe's line, C on the scleral spur, D behind the scleral spur, and E on the ciliary body. After looking for the insertion of the iris, we look the width of the angle between the iris and cornea. If it is totally open, it is 40, 30, or maybe 10, maybe 20, maybe slit. We measure the angle. Then we look to the peripheral iris. It's either steep or anterior convex, which is more common in hypermetrope, R or regular, which is present in most of the normal population, or queer, which is present in myope, especially in pigmented glaucoma. Lastly, we look for the trabecular meshwork pigmentation and grade it from 0 to 4. So by Spess classification, we can say A, 10, R, 0. Level of iris insertion, the angle, width of the angle, the configuration of the peripheral iris, and pigmentation. Another easier classification or grading is the Scheffer and the modified Scheffer. The Scheffer classification depends only by the width of the angle. Grade 0, angle totally closed. Grade 1, it is 10 degrees. Grade 2, it is 20 degrees. Grade 3, it is 30 degrees. Grade 4, it is 40 degrees. Or the modified Scheffer depends on what you see in the angle. If the Schwalbe's line is not visible, you can see nothing of the angle, it is grade 0. You can see only the Schwalbe's line, it is grade 1. You can see anterior trabecular meshwork, it is grade 2. You can see the scleral spur, it is grade 3. Or you can see the ciliary body bend, it is grade 4. As you can see here, grade 0 and grade 1, these patients are at higher risk for angle occlusion. Grade 2 is medium risk, while grade 3 and 4, very low risk for angle occlusion. We look, as I said, on the periphery of the iris. In myopes, it is concave, as you can see in this picture. In hypermeropes, it is convex. Abnormal convexity leads to pupillary block, and abnormal concavity leads to pigment dispersion syndrome. And we look for the abnormal lustrol to diagnose plateau iris. Sometimes then we look for the ciliary body band. Ciliary body band, as you can see here, it is extremely wide in angle recession due to blunt trauma or in the presence of cyclodialysis cleft. The sclera spur, it is posterior to the trabecular meshwork. It is the attachment of the ciliary body and the insertion of longitudinal muscles of ciliary body, may be obscured by iris processes, iris bombay, peripheral anterior synechia, or pigments in the angle. The trabecular meshwork, as we said, anterior trabecular meshwork, which is non-functional, posterior trabecular meshwork, which is functional. Usually, it is more pigmented inferiorly. It can be identified by Schwalbe's line or either by presence of blood in the Schlemm's canal posterior to it. Sometimes we see developmental anomalies with gonioscopy, like posterior embryotoxin or Axenfeld anomaly. So, to end our presentation, we must stress that gonioscopy is a fundamental part of ophthalmic evaluation. It should be done for all the patients. It leads to confirmation of normal angle structure, determination of narrowness or closure of anterior chamber angle, grading of angle widths, and we can see pathological findings as neosalization or synechia. Needs to be performed routinely. So as Dr. Abdelhamid said in the beginning, gonioscopy is very essential. We must all master it. Never treat glaucoma patient without gonioscopy. As we all know, if we're treating primary open angle glaucoma, management is totally different than management of chronic angle closure glaucoma. If we're treating patients primary angle closure suspects, differs from primary angle closure glaucoma. So please always try to master gonioscopy and do. Thank you for your attention.
Thank you, Dr. Ahmed Hassan, very much for this simple, very nice, illustrative lecture. Definitely, it is a message for all ophthalmologists to try to master the technique, to have in their clinics the gonioscopy lens as a part of their tools they use for examining their patients, and to try to start with gonioscopy for every patient coming, even for just spectacle change or refraction assessment. Dr. Ahmed Hassan, we'll start questions now. The first question, do you recommend that the 3-mirror lens can replace the 4-mirror, or by rephrasing, do you think that we can rely upon the 3-mirror gonioscopy only?
We can put it the reverse side. 4-mirror lens can replace Goldman lens, but Goldman lens cannot replace 4-mirror lens. Because, as I said before, very important part in the examination is indentation gonioscopy. Some people say we can do indentation gonioscopy by Goldman, but it actually widens the angle, it narrows the angle rather than widening it. So if you want to have only one lens, have the 4-mirror lens. It's somehow difficult to use than the 3-mirror lens because you don't use coupling media, and the patients needs to be somehow cooperative. And most of the doctors are not acquainted to it. While 4-mirror lens, 3-mirror lens, any patient, any doctor who do laser or examine the fundus, you can use it easily. But 4-mirror is more important in glaucoma.
I would like to welcome our guests today, Professor Dr. Muhammad Saad and Professor Dr. Nader Bayoumi. Please, I hope that you can join us in order to make use of your addition to this webinar. There are many questions also, Dr. Hussam. One of the questions for corneal wedge, which angle of the slit lamp do you use?
Usually I use 60 degrees angle.
Do you like to offset the beam or the regular oblique beam?
No, it is 60 degrees, the regular oblique beam, short, 2 to 3 millimeter, and wide.
And wide. Okay. And I will revise an important point, that the corneal wedge, by which we can identify the start anterior beginning of the angle, the Schwalbe line, the termination of the cornea, and the beginning of the Schwalbe line, or the beginning of the angle. Another question, please, Dr. Hussam. There is a question asking if the anterior segment OCT can replace the gonioscopy or not.
Actually, if you are going to refer for imaging, the most important, I think, is the UBM. It gives you a clear view about the angle. Anterior segment OCT, it does not give a panoramic view of the angle like UBM. Also, by the anterior segment OCT or other, you cannot do indentation gonioscopy, while you can do it only by gonioscopy. So it can't replace, it may help.
Professor Hussam, good evening.
Good evening, Dr. Nader.
ازي حضرتك دكتور حسام؟ This is Nader Bayoumi.
اهلا ازيك يا نادر.
ازي حضرتك دكتور حسام؟ Thank you very much for this excellent talk and presentation. It's really always an honor and a delight to be a faithful student, sir. I would like you, sir, to highlight to us the importance of a rather simple but important issue, the issue of examining or doing gonioscopy on both eyes whenever this is possible. So can you please give us a comment on the importance of gonioscoping both eyes and not just focusing on the eye of interest?
First of all, if you are asking if you're going to do it simultaneously, the only way to do simultaneously by using of the copy lens.
No, sequentially, but sometimes most of us are just excited by finding one eye and they don't go to the other eye. So I want to highlight the importance of doing both eyes.
Extremely important, because usually when we have a narrow angle, it is a bilateral disease. And if we have a narrow angle unilateral, we think about secondary mechanism, not a primary angle closure.
Sure, sir.
Most important, as I was talking in a seminar, in a webinar 2 weeks ago about angle closure glaucoma, I highlighted that always never forget to examine the other eye and do prophylactic iridectomy if the patient had an acute attack in one eye. So it is very important to examine.
Another issue, speaking of angle closure glaucoma as well, what about the what they call looking above the hill? If there is an extensive convex peripheral iris, is there any recommendation or practical tip from you, sir, about examining such gonioscoping such difficult narrow angles in which the peripheral iris is so convex that we cannot find even the angle structures?
Here we do what we call indentation gonioscopy.
Yes.
The use of the 4 mirror lens, when we press in the center, aqueous is pushed to the periphery, and if there is no complete synovial closure, it will help the iris to move backwards a little bit so we can see details of the angle.
Sure, sir. Thank you very much.
Thank you very much, Dr. Nader.
Dr. Hussam,
دكتور حسام.
دكتور محمد اتفضل.
بصراحة المحاضرة رائعة.
منور يا محمد.
وما سابت لناش حاجة نقولها يعني.
لا اتفضل.
أنا بس كنت عايز يعني أنبه إن الجونيوسكوبي ده جزء مهمل تملي في الاكزامينيشن اوف ذا اي. وعايزين نشجع اليانج دكتورز تو بروسيد وذ جونيوسكوبي. بس لازم برضو ننوه إلى إن sometimes there are multiple difficulties in doing gonioscopy. فكنت عايزك تكلمنا شوية على الديفيكولتيز خصوصا للبيجنرز اللي بيواجهوها لما يجوا يعملوا جونيوسكوبي and the common mistakes in interpretation even of the signs they detect in gonioscopy.
First, I advise all the beginners to start with the Goldman 3 mirror. As I said, it's much easier than the Ford mirror, and a lot of ophthalmologists are accustomed to it by doing laser to the retina or examine the periphery of the retina with the 3 mirror lens. Of course, when you're going to start doing gonioscopy, choose a cooperative patient. Uncooperative patient is a hell to do gonioscopy. Second, patients with sunken globe or narrow palpebral fissure, it's always difficult to do gonioscopy with. So start with patient with wide palpebral fissure, protruding eyes, avoid sunken globe in the beginning, and first of all, you must explain to the patient what you are going to do. The أول step. One of the common mistakes, and sometimes there is air inside which will not allow me to examine the angle greatly. Avoid extra pressure by Goldman lens, because extra pressure by Goldman lens may narrow the angle of the anterior chamber على عكس ال4 mirror lens. Always examine in a dark room as possible, because if the room is highly illuminated, this will lead to pupillary constriction, وده هيدينا false wide angle عن الطبيعي بتاعتها. Use 60 degrees, الانجل بتاع سي كلام تبقى 60 degrees، وزي ما قلت short beam 2 to 3 millimeter and wide beam, not narrow beam, in order to see the structure. After mastering examination with the 3 mirror Goldman lens, next step is we go to the 4 mirror lens. As I said, it's much more difficult على اساس ان البيشنت الثانيه البيشنت مع كابلنج ميديا اللينس تبقى فيكس خلاص، زي ما تقولوا قفشت في عين العيان. هنا لا، we need the patient to be cooperative, looking straight forward, and also take care not to press too much because it will lead to wrinkles of the cornea. لو برضو الدكتور محمد by your experience تقدر تضيف لنا ايه الكومن ميستيكس اللي بيقع فيها البيجنرز؟
هو برضه من ضمن الحاجات اللي عايز الفت فيها
محمد,
للبيجنرز.
we have English speaking attendees and they are asking for English language, please. Thank you, Dr. Muhammad.
For the new glaucoma patients, you have to do careful and illustrated gonioscopy. But those coming for follow-up, you will do the gonioscopy every time they come to you, or how frequent you do the gonioscopy for the patients coming for follow-up?
This is a question.
Is there any indication that you have to repeat your gonioscopy for the patients coming to you regularly for follow-up?
Yes, I usually do it routinely if the patient his intraocular pressure is controlled, his visual field is stable, and the optic disc is stable. I do it routinely from 6 months to 1 year. But if the patient comes with unexplained increase of the intraocular pressure or poorly controlled, I do another gonioscopy, because as you all know, most of the patients are old. Sometimes the anteroposterior diameter of the lens increased and a narrow element is added on the open angle glaucoma. So whenever you suspect something is wrong, do another gonioscopy. But if the patient is straightforward, I do it every 6 months to 1 year, not every visit.
The last question about the order of examination of the angle, because we all know that the inferior angle is the wider part, while the superior angle is the narrower part. If you use the Goldman 1 mirror or 3 mirror lens, what is the order to examine the angle in these cases?
Usually, I start with the inferior angle, which is wider and much easier to recognize, and then I rotate the lens clockwise 360 degrees and finish with the superior part.
Thank you very much. It was an excellent presentation.
Thank you very much, Dr. Muhammad, for your questions.
Hassan, we have a lot of questions. They are asking about the settings during the gonioscopy as regards the dilatation, as regards the room illumination, and another question, repeated question about the angle used during the corneal wedge. So we'll start by the setting as regards the dilatation. Do you prefer dilatation, and does it affect the examination or not?
I never do dilatation for a glaucoma patient before doing gonioscopy. Because if you dilate the patient and it is an angle closure, you will let the precipitate an acute attack. So I examine without dilatation. Secondly, I diminish the illumination as much as I can in order to avoid pupillary constriction, extra pupillary constriction. My angle is 60 degrees. I use narrow beam, a wide beam, about 3 millimeter height.
A question about gonioscopy for children. Definitely it is under GA, and definitely it needs special lenses like the Coupé lens, which should be available in order to examine children. About the material that can be used, the 3 mirror Goldman needs methyl cellulose, while the 4-mirror does not need anything. It's just the tear film, because it fits in the cornea.
Actually, there are new 3 Goldman mirror you can coupling with fluid only. You don't need methyl cellulose, but it needs a cooperative patient.
Perfect. You change the angle of slit lamp. Yes, we mentioned this. What are the best coupling media? Just fluid, the tear film. Okay, we finished all the questions up till now. I want to ask you some questions concerning the plateau iris configuration. Do you rely totally upon gonioscopy in order to diagnose plateau iris?
When I'm in doubt, I do UBM. It shows very well the double hump side. But if you speak on clinical practice, if I'm worried I cannot distinguish exactly between plateau iris configuration and pupillary block, I do iridectomy and see. If it is the attack is resolved completely, it is a pupillary block. If not, it is a plateau iris, and then I go for peripheral laser iridoplasty.
So this is also another answer for the question of Professor Dr. Muhammad Saad about that the frequency of gonioscopy should be done after any intervention. For example, after YAG iridotomy, after peripheral laser iridoplasty, after cataract surgery. So these interventions might necessitate another another examination by gonioscopy in order to assess the changes that have occurred in the angle because of the procedure. Because sometimes you might have double pathology, like pupillary block and non-pupillary block together, like cases of plateau iris, for example. You might diagnose plateau iris, peripheral iridectomy might give benefit, partial, yet the condition is not totally resolved.
And another important, I want to stress it again, I answered Dr. Muhammad about it. Whenever I'm following a patient with primary open-angle glaucoma conferred by gonioscopy, and there's something abnormal happening, pressure started to rise rapidly, or there's progression in the visual field or cupping, here I must do another gonioscopy to exclude additional element of angle closure due to increased thickness of the lens with age.
Dr. Hussam, do you think that cases which are prone to narrow angle glaucoma, what degree of hyperopia do you feel they are liable for this condition? Because some ophthalmologists might think that they need +4, +5 hyperopia for this condition to precipitate or to predispose to this condition. I think that low hyperopias might be more prone to this condition more than the +4 or +5. Do you think so?
You know, I'm much older than you. During my residency, we were taught that angle closure glaucoma occurs only after 70 years of age in patients +4 or +5. Actually, now we can see 40 years of age, 50 years of age, and in hyperopes +2 or +3. It depends about the width of the angle of the anterior chamber, which is not always correlated by the degree of hypermetropy.
Another important point regarding the angle closure, the new item of the lens vault. This is another factor that was missing in evaluation of our angle. We were depending only on the configuration of the iris and the narrowness of the angle, but the lens vault now has an increasing role in cases of angle closure. So in patient, even emmetrope, when there is something wrong in the lens vault, may initiate angle closure even if the patient is emmetrope.
Which means that the dynamic condition of the angle is a variable status, exactly like we are mentioning the dynamic gonioscopy. So we are as if we are putting the angle in variable change, mechanical change, while our examination because when we are doing the gonioscopy indentation, we are pushing the center of the cornea backwards, pushing fluid and opening an angle. And when we are asking the patient to look towards the angle we are examining, we are opening the angle more. And when we are making 3-mirror or Goldman 3-mirror gonioscopy, we are doing the reverse. So this is some sort of dynamic gonioscopy. Similar to this, the condition of the angle in the real life, it is prone to variable changes, especially regarding the congestion of the iris, the thickness of the iris, the lens vault, as Professor Dr. Muhammad Saad mentioned, which is something very important and can be measured by selective choice of measurements during the anterior segment OCT and UBM by putting a line joining the scleral spur on the nasal and temporal sides and putting the lens, how much volume of the lens is related to this line. So it is a dynamic state which might put the patient in a condition, yet you are not able to explain what's happening by just the hyperopia or by just the crowdiness of the angle. One of the questions which we are seeing now, does the anterior angle OCT will replace the anterior UBM or the UBM, Dr. Hussein?
لا ما سمعتش، خط قطع.
Does the anterior segment OCT replace the UBM?
لا, UBM is much better in examination of the ankle.
Yes, because the UBM gives an idea about structures behind the iris, which is not possible by means of the anterior segment OCT.
And one important thing here, sorry for the interruption, ان لازم instruct برضه الاكزامينر اللي بيعمل to instruct the examiner who's making the UBM is do it in a dark illumination, because if we do it with a strong daylight illumination, it will lead to pupillar restriction and it give me false impression of wider angle.
سؤال يفيد الطلبه بتوعنا يا دكتور حسام. ايه differential diagnosis بتاع hyperpigmented angle؟
If we see hyperpigmented angle, أول حاجتين بفكر فيهم اللي هو pigmentary glaucoma. Here there is increased pigmentation in the posterior part of the trabecular meshwork. Also, there is increased pigmentation in pseudo-exfoliation glaucoma. Here the pigmentation is in the form of a line at the Schwalbe's line or anterior to it. It's called Sampaolesi line. Also, in patients with chronic uveitis, we may have increased pigmentation. But the most common two causes we think about is the pigmentary glaucoma or pigment dispersion in general and pseudo-exfoliation.
And also history of trauma.
And this, of course.
We have with us Dr. Mustafa Yaoub. He's one of our mentors in glaucoma, and he's joining us asking a question for Dr.
I'd like to salute Dr. Mustafa Yaoub. He's an old friend, and I haven't seen him for a long period.
I remember a word or a sentence he always mentioned. Please put your Zeiss lens in your pocket and move with it in your clinic in order to do the gonioscopy for any patient. He has a question for you, Dr. Hussam. There are cases of anterior segment relative microphthalmia. So if hyperopic or not, gonioscopy is a must. Thank you.
Yes, of course. Gonioscopy is a must, as I said, in all patients of glaucoma, and especially if patients of anterior segment microphthalmia. So it is a must.
There is a question about the parameters for temporal and nasal parts. The attendees heard a lot about superior and inferior angle. That's why they are asking about temporal and nasal parts.
No, usually inferior is the most wider part of the angle. Superiorly is less. Temporal and nasal usually are in between superior and inferior.
Rotation
of
the
normal angle.
Yes. A doctor is asking about rotation of the lens or focusing on other mirrors. I think she missed or he missed that the 4-mirror lens you might not need the rotation, but you should put it in a way in order to examine every clock hour or 2 clock hours at a time while looking, but you don't need rotation. The rotation is needed in the 3 mirror only or the 1 mirror only. Do we need to rotate the 3 mirrors to see to 360, or just one view is enough to know type of glaucoma? Dr. Hassan, please. You
Yeah.
need.
I need to rotate, of course, 360 degrees. As I said, inferior is the most wider part, but I must assess all the areas. There may be areas where there is synechia or maybe angle partly occluded, so I must rotate 360 degrees.
One of the questions about neovascular glaucoma. Do you feel that gonioscopy is important in diagnosis of any elevated intraocular pressure in diabetics, or it should be routine even if intraocular pressure is not elevated?
First of all, and this question has two parts. If the patient's pressure is elevated, we must differentiate between neovascular glaucoma with open angle and neovascular glaucoma with closed angle. This is separate. And of course, we must examine in all diabetic patients with gonioscopy. But before doing gonioscopy, one important point I want to stress on, always examine the iris and the pupillary border before pupillary dilatation. Most retina specialists, whenever they're seeing the patient, they dilate him before they see him. No, you must examine first to see the pupillary border, looking for dubiosus iridis, and then examine the angle to see whether there is new vessels or not. And this is what we called pre-glaucoma stage in neovascular glaucoma. You got the answer?
Yes, definitely. Dr. Mustafa Yaqub has his comment on the rotation. Yes, the 4 mirror does not need the rotation. It can be slided easily on the cornea up, down, and right, up, down, right, and left to see the depth of the angle recess. Yes, definitely. And you can also help by asking the patient to direct his gaze towards the angle examined. This may be the reason why we use the 4 mirror lens. So we are examining the 4 directions at the same time without rotation. Just we are asking the patient to move his direction, and we are just indenting or sliding the lens in an oblique manner to indent and to open the angle we are examining. What kind of patients do you avoid doing gonioscopy, or should you be very careful when doing gonioscopy? So he's asking about precautions and contraindications for gonioscopy, Dr. Hussein.
First of all, it depends upon the condition of the cornea. If the patient has corneal abrasion, of course, we cannot do gonioscopy. Or sometimes patients with increased intraocular pressure and they have epithelial edema, if we try to do gonioscopy in this patient, we will not have a proper visualization, and also we may lead to appearance of corneal ulcer. So my only concern is about the status of the cornea. If the patient is infected, he has infection, of course I don't do gonioscopy until I clear the infection. But mostly—
Is there any relation between gonioscopy and COVID-19?
According to my knowledge, COVID is being transmitted by tears. So gonioscopy or even telemetry, if we don't sterilize our instrument good, we may transmit infection.
How can we sterilize our gonioscopy lens?
The best thing is to wash it with soap and water and dry it. If we're going to sterilize it with alcohol, by time the quality of the mirror will be affected. So in my opinion, the best thing is soap and water and dry it.
Another question from attendees. Nasal and temporal angle parts need special attention to beam rotation horizontally and to beam from opposite direction of the angle to be examined. I don't understand exactly what do you mean, Muhammad Sami Mahmoud. Nasal and temporal angle parts need special attention to beam rotation horizontally. Well, actually, the 4 mirror, Muhammad, it has 4 mirrors. So you are examining a mirror for the inferior angle, mirror for the superior, mirror for the nasal, mirror for the temporal. Concerning the Goldman, you need to rotate in order to see the four angles. I hope I have answered your question.
Dr. Abdul Hamid,
Yes, sir.
gonioscopy is an art.
Definitely.
And by experience, our colleagues and students will learn how to deal with everything during gonioscopy. You have to add to what Dr. Hussam said. Sometimes we need to tilt our gonioscopy lens, and sometimes we have to move and play with light with the light beam in order to identify the structures and detect the exact width of the angle. So it will need some experience, and this experience will develop by time in order to play with the light, to play with the beam, and to tilt the lens in order to avoid certain difficulties and to examine every quadrant precisely.
I would like to add something, Dr. Muhammad. When you are going to start your 4-mirror gonioscopy, you should be gentle at the very beginning, because when you are gentle, you can identify the oppositional condition and at which clock hours. When you are pushing and doing the indentation, you are opening an oppositional condition. So being gentle at the beginning will diagnose the actual status of the lens. And doing the indentation and pushing the central part of the cornea, you will open the oppositional condition and diagnose if there is an underlying synechial closure or not. Do you agree with me, Dr. Hussam?
Yes, of course. Always start with general. There's one point I want to say about the question about the temporal nasal and about Dr. Muhammad about we can change the light beam from vertical to oblique to horizontal to be perpendicular to the position of the mirror. I mean,
Right.
if the mirror is at 12 o'clock, we make it perpendicular to it. If it is, what I was saying, I mean how to start with, but when you start examining, if the mirror is at 10.5 or 1.5, you make it oblique. If you're examining the horizontal, we make the beam horizontal. This will help. And as Dr. Muhammad said, it is an art. We only give you the principles, and then by examining, you'll earn more tricks about how to examine.
Do you use your right hand for the left eye and your left hand for the right eye?
Actually, I tried, but I'm accustomed using only my left hand during the lens, during using any volc or anything. I use only my left hand.
Okay.
My son sometimes examine with me. He uses the right and left. I try always to use my left eye, left hand.
Dr. Muhammad, do you use both your hands, the right and the
No,
left?
just one hand.
Just one hand. It's nice to use the right hand for the left eye and your left hand for the right eye.
It is much easier, but you
Yes.
know, if you trained on something, as I said, you can't. Okay.
Yeah, definitely. It is an experience that everyone should master in the way he would like and makes it easy during examining. Dr. Muhammad and Dr. Hussam and Dr. Nader, if you have a patient, this is a message we can terminate our meeting today with this question. And after that, we can, I think our sponsor would like to offer us a movie, I think so. And the last question, you have a patient in your clinic, and this patient is 60 years old, and he has intraocular pressure 60 millimeter mercury. What are the chances that may change your plan after doing gonioscopy? You have a patient 60 years old, phakic. His intraocular pressure is 30, 35. How does gonioscopy would offer you different plans for management? This is an important question to my mind, because all ophthalmologists would like to write or to prescribe immediately tension lowering measures. I'm not going to talk about a condition with glaucoma suspect. You have a patient with intraocular pressure 35, so he's glaucomatous, he has a problem. But how can gonioscopy will guide you? Please, Dr. Hussein.
First of all, I must ask the patient about if there is pain or not, because here it differs. If the patient has gradual increase of his intraocular pressure, the patient will not complain of pain, whether primary open angle or chronic angle closure glaucoma. If the patient's complaints of pain, here I put in my mind it may be an acute or subacute attack. Secondly, I must do, of course, gonioscopy to know whether it is a primary open angle glaucoma. Then here I start medical therapy. But this is unusual if the patient complains of pain. Usually there is an acute element. If the angle is not open, then I do indentation gonioscopy to know whether this is synechial closure, and it is a chronic angle closure glaucoma, and here the management differs, or this is primary angle closure glaucoma with increased intraocular pressure. Here I go for iridectomy or lens extraction. Chronic angle closure, I do medical treatment plus iridectomy and plus or minus lens extraction. Primary open angle glaucoma with open angle, I go directly for medical treatment. So as I said before in a lecture a few years ago, not each glaucoma is a primary open angle glaucoma. We must exclude narrow angle glaucoma. We must exclude secondary glaucomas. Also, one important point, if I do gonioscopy here, I may suspect pigmented glaucoma or pseudo-exfoliation glaucoma, especially if the patient is a young male with moderate myopia, with pressure 35, most probably he is a pigmented glaucoma. So exclude primary from secondary, and in primary exclude or differentiate open with narrow angle.
Thank you, Dr. Hassan, for this illustrative answer and this nice presentation. Dr. Muhammad, would you like to add anything?
I would like to add, we have to examine the lens carefully in this patient with 60 years of age and 35 millimeter mercury of pressure, because we now know that lens surgery became a part in the management of glaucoma, whether it is an open angle or closed angle, and it is much more important in narrow angles and closed angles. If in this patient I find any sort of cataract, so cataract extraction in this patient will help control the intraocular pressure. And I will consider this in the future management of such a patient. The state of the lens is very important in managing these cases with glaucoma.
May I add one small addition, please?
Definitely.
Of course, totally agreed with our esteemed professors. Just want to highlight the importance of the uveitic glaucomas, the presence of peripheral anterior synechia. Although, of course, in a 60 years old, the uveitic entity is less common than in a younger age, but again, it is an entity to consider. And especially, and another thing, as Professor Sam highlighted during the presentation, is the neovascular glaucoma issue. To differentiate between the open angle and the closed angle stage of neovascular glaucoma, more often than not, this is the primary presentation of a patient with neovascularization, be it a vascular occlusion, be it a proliferative diabetic retinopathy. Sometimes the first presentation is an elevation of the intraocular pressure without the diabetic condition or the vascular occlusion being recognized. And gonioscopy here may be the only clue that would highlight the presence of peripheral anterior synechia or neovascularization of the angle, and hence raise the issue of neovascularization, especially that, as Professor Sam highlighted, we don't routinely dilate patients presenting to a glaucoma practice. So just to highlight the secondary glaucomas, uveitis, neovascular in the clinical scenario asked about. Thank you.
Thank you, our dear guest. Thank you, Dr. Hussam. Our Islam, Orchidia, do you want to add something to this virtual meeting?
Thank you, Dr. Abdul Hamid. Thank you, Dr. Ahmed, Dr. Nader, Dr. Muhammad Saad.
I think we made benefit today from this webinar. I would like to thank greatly my professor, Dr. Ahmed Hussam, for his presence with us today and for his valuable knowledge he offered us. And we are looking forward to see you again. Thanks, Orchidia. Thank you, RM, and good evening.
Thank you, Dr. Abdul Hamid, for this nice organization. My main thanks to Orchidia and, of course, my colleagues, Professor Muhammad Saad and Professor Nader Bayoumi, for enrichment of our discussion.
Thank you very much, sir.
Thank you.
Thank you very much, sir.
Good evening. Thank you.
Thank you, Doctor.